That's good.
Let's just test it and make sure that I can hear you okay.
Hi, everybody. Thank you so much for waiting, guys. I am so sorry. I apologize for the delay. I was actually stuck in surgery, but I was able to get out just now. Thank you all so much for coming here and spending a few minutes talking about some of the issues that are really near and dear to my heart, because we spend a lot of time dealing with atrial fibrillation. And I wanted to share some of the things that, some of the old issues and some of the new perspectives and new approaches to treatment of atrial fibrillation. Obviously, an old and a very common condition that we see in cardiology. Certainly something that we encounter quite a bit. But I think that we do have a number of new approaches and new tools to deal with this frequently difficult problem. And I wanted to go over some of the new techniques that we have. And hopefully after we have a chance to go through a few slides, perhaps we can have a discussion where you can ask some questions or have some thoughts about some of these issues, and maybe we can have a discussion. Let's see if we can get the computer to advance. So if you look at the most common cause of death in the United States, it's obviously heart disease. And there are several different aspects of heart disease that get people in trouble. The most common and the most well-recognized problem that we see is heart attacks. That's an issue that that is extremely common and has gotten quite a bit of attention over the last several decades. As we got as a medical community to understand it a little bit better, as well as the awareness of the lay public about the need to intervene on these issues as far as modifying the risk factors and controlling the cholesterol and diet and the exercise. We've actually seen that over the last couple of decades, death from heart attacks has been going way down, and it probably has to do with quite a bit of efforts that were put into prevention of heart disease. We're excited that that part of heart disease has been getting under better control, although it's still fairly common. The other problem that we see is heart failure, which is a result of old heart attacks or other conditions that wear out the heart muscle and make it weak and interfere with the normal function of the heart. It's a relatively common problem. We deal with it quite a bit. Unfortunately, over the last several decades, again, we've made quite a bit of progress in understanding the condition and developing new tools to deal with it. The one problem that we don't really fully have the grasp on is the electrical system of the heart. The heart is a pump, and just like any other pump that you may have in the house or in the car, it has an electrical system that makes it run and makes it run optimally. It adjusts the heart rate and it improves the efficiency of the operation, make sure that it pumps regularly. When the electrical system that regulates the heartbeat malfunctions, patients may have significant problems, sometimes severe problems leading to death, sometimes milder problems that just lead to dysfunction that makes the heart run inefficiently and generating quite a bit of symptoms. If you look at the spectrum of the different electrical conditions, electrical malfunctions or arrhythmias that we encounter, one thing stands out. Atrial fibrillation is not only the most common condition that we see, but if you add up all the other conditions together, whether they are abnormal heart rhythms from the bottom chamber of the heart or other types of arrhythmias, or slow heartbeats or rapid heartbeats, atrial fibrillation is more common than all of those combined. So that kind of sets the stage for why atrial fibrillation is important, why dealing with atrial fibrillation is important. Moreover, if you look at the incidence of atrial fibrillation, how common it is, if you look at the number of demographic studies, it's not only common, but the incidence is increasing. It's increasing rapidly. There are millions of people in this country that are affected by this condition. We really need to have a handle on how to treat this and how to handle it. There are two problems that you get from atrial fibrillation, two categories of problems. One problem is the symptoms. When your heart runs irregular, people may have significant symptoms. Palpitation, sensation that the heart's just not running quite right, shortness of breath, fatigue, chest pain. Those are common symptoms related to atrial fibrillation. In some people, they can be well tolerated. In other people, they're debilitating and make people very sick, make people come to the emergency room. The other big category of problems is the strokes related to atrial fibrillation. Unfortunately, atrial fibrillation is one of the most common causes of stroke, and it is a result of blood clots forming in the heart, and the heart's pumping inefficiently. The blood kind of stagnates in the top chamber of the heart. Sometimes you can form small clots. These small blood clots, as they travel out of the heart into the brain, block off the blood vessels in the brain, and a tiny little blood clot that is really a fraction of an inch in its size can cause devastating strokes. Studies have shown that strokes related to atrial fibrillation are typically much larger and much more debilitating than other types of strokes. When you look at patients with atrial fibrillation, you see that the rate of stroke and the risk of stroke is about 5 times that of general population. So there's a number of treatment options that we have, and there's a number of things that we can do to try to reduce these symptoms and reduce the risk of stroke. There are generally 3 categories of treatments that we have. One thing that we've had for decades is medications, and that's kind of self-explanatory. There's a number of medicines that we can use to control atrial fibrillation. This is something that we've had for many, many years. It's common. Everybody has it. But in addition, we have newer tools that we'll go over here in a few minutes that allow us to control atrial fibrillation, perhaps in some ways better than with medication. One is the ablation procedures, which allow us to get in and find some of the problems that are causing the heart to beat irregularly, burn out those problems, make those go away. And the other thing that we may want to talk about here in a few minutes is procedures to reduce the stroke without taking medications by blocking off the spot where these blood clots form. And that's called left atrial appendage closure procedures. These are this is basically procedures and devices that allow us to close off the left atrial appendage where blood clots come from. So the obvious first choice for treating some of these medications, and this is something that's available everywhere, it's a common problem, is medications. Here is an abridged list of medications that are available for treatment of atrial fibrillation. As you can see, this list is very long, and this is not even all the medicines that we have for treatment of atrial fibrillation. The obvious problem with this picture is that if any one of these medicines would work very well, why would you need so many? So the problem is that although in many patients you can get the arrhythmia under control with medications, in the majority of patients the success is not so great, and frequently we need to go on to bigger and better things to treat the condition. So the advantage of medications is it's simple. Take some pills, and we'll see what happens. Usually it gets things better. Unfortunately, the disadvantages of medications is that they don't work so well. None of the medicines that we have a success rate better than 50%. Most of the medicines have very limited ability to control the arrhythmia and get it under control. The other problem is the side effects, because basically there's no such thing as a medicine with no side effects. Any medicine that we use has potential side effects and commonly have side effects. Typically, what we do is we try to give the lowest dose of medicine, hoping that you don't get the side effects, but when that's ineffective, we continue to increase the dose, and at some point, the side effects become intolerable and we have to quit and switch to some other strategy. The other problem with medications is it's not something that fixes the problem. It's a way to suppress the problem. So you do okay as long as you continue to take the medicine. If you stop the medicine, the problem comes back. So it ends up being a lifelong problem where you continue to take medicines all day, every day. You just kind of carry on with it. So those are some of the challenges that we have with medical treatment of atrial fibrillation, specifically, but any other arrhythmias in general. So there comes in the concept of ablation, and this is something that has been the ablation procedures have been around for a couple of decades, but it has been difficult to treat atrial fibrillation because of the number of problems that I'll show you here in a moment. No. All right. Anyway, this is the normal electrical system of the heart. The impulses of the heartbeats are generated in the top chamber of the heart in the area that's called sinus nomen. It is an area of the heart that determines how fast the heart should beat. It goes slow at rest. It goes fast with exercise or exertion or under stress. It adjusts the heart rate. The heartbeats spread to the other areas of the heart through the special tissues, electrical wiring that makes sure that the right and left and the top and bottom chambers of the heart all work in sync with each other. And in the normal heart, this is what it looks like. The whole thing works in sync. The top and the bottom chambers of the heart work together. In patients with an abnormal heart rhythm, there's frequently a spot that competes with the normal heartbeat and interferes with the way the heartbeat runs. So if you have an area of scarring in abnormal tissue that interferes with the normal heartbeats, that creates problems. So ablation is a procedure where we introduce small electrical wires through a needle stick through one of the blood vessels, typically in the leg. We advance the wires into the heart under X-ray guidance, find the spot that's causing trouble, and then we go and try to destroy that spot. Unfortunately, the problem with some of these spots is that some targets are just really hard to hit, as this video demonstrates. So you really are frequently looking for a very tiny spot that's really hard to fit into, that may be kind of way far off and difficult to get in. Additionally, in the setting of atrial fibrillation, the problem comes up that there is not one spot that causes trouble, but there's usually multiple areas, there's multiple spots that are causing trouble. So if you go and knock out a couple of them, that's usually not enough. You would need to go and kind of find all of them, or most of them, to try to get it under control. So when you have multiple different areas, it potentially creates a problem that's much more difficult to deal with. Fortunately, over the last decade, we've developed a number of different tools that help us understand where the abnormal heart rhythms are coming from and help us track them down and keep track of where we are and where we should be and where we've been and where we haven't been. This is an example of a computer model that we use for ablation of atrial fibrillation. And basically what we do is we introduce a catheter into the heart and position it in the left atrium, which is typically the source of abnormal heart rhythms in atrial fibrillation. The catheter has a tiny little GPS transceiver that tells us where the catheter is. By moving the catheter all around the heart, we can create an electronic replica, three-dimensional model of the heart that allows us to see where the healthy tissues are and where the scar areas are. It also allows us to keep track of where we've burned, where we've destroyed scar tissue, and where we haven't been. By doing that, it allows us to work through the procedure much more efficiently. So here is an example of the green area is the heart chamber, the left atrium that has the problems, and the little red tubes are just kind of cartoons that represent the pulmonary veins, the blood vessels that come into the heart, and we don't really target those. We put them in there for reference so we can know which side is up and which side is down. But then the little red dots are the spots where we've burned the abnormal heart rhythms and destroyed the abnormal heart rhythms. You can see that the abnormal heart rhythms that come from the area of the pulmonary veins will be trapped within these fire lines, within these circles and these areas that we create to trap the abnormal heart rhythms inside so that they can't spread and affect the rest of the heartbeat. So there's a number of advantages to the ablation procedure vis-a-vis medications. The most obvious advantage is that the ablation procedure tends to be much more successful than medications. Although the success rate with catheter ablation is clearly not 100%, the success rate with ablation is probably twice as good as with medication. So we see much better efficacy with ablation than we do with medication. The other big benefit of an ablation is that this is a procedure that you do once, and some people you may need to do it more than once, but you do it one time and you move on. You don't have to do the ablation every single day like you do with medication. So that's an attractive option for a number of people that basically, instead of having chronic suppressive therapy that you take every single day, it's a one-time intervention. You go and you fix it, and if it's successful, you move on. The obvious downside is that it's an invasive procedure. It carries a small risk associated with it. There's no such thing as a procedure that carries no risk. Anytime that you put in catheters in the heart and try to do any type of an operation, there is a small risk. And the challenge is to try to kind of look at the patient and the situation and decide. In some patients, the risk is small and it's worthwhile to go and do this. In some people, the risk is higher, and perhaps medications would be a better alternative. So it's a chance to figure out which one is best. But it obviously is a great option to have all these options available. So basically, if you can choose this one or that one, depending on the patient, that certainly gives us a great advantage. This is a representative study of, there's a number of studies that have looked at ablation versus medications, and what we've seen is that the results of these studies are fairly consistent. The success rate with eliminating atrial fibrillation or controlling atrial fibrillation is clearly much better with an ablation. You can see that the success rate is not perfect, it's not 100%, but it certainly is better than with medications. When you look at the success rate, unfortunately, it's a little bit difficult to define the success rate because it depends on the type of patients, it depends on the type of atrial fibrillation that we're addressing. In patients who have no structural heart disease and where the arrhythmia comes and goes, the success rate is pretty high. It's on the order of 80 to 90%. In patients with a longer lasting atrial fibrillation that has been there for a while and is persistent, the success rate is probably closer to 70%. In patients who have been in an arrhythmia for years and have extensive scarring, or patients who have a lot of other types of heart disease, the success rate is even lower. It's in the order of 50%. But depending on the type of atrial fibrillation and depending on the type of patients and the risk of complications, we can frequently determine what's the best strategy. In somebody who has low risk of the procedure and high success rate, we go straight for the ablation. In somebody where the success rate is going to be on the order of 50% and there's potential for complications, we'll go and say, maybe you should try some medicines first. But again, this is a great thing that we have the option of doing this one or the other one, depending on the patient situation. So this has been our experience in doing atrial fibrillation ablation. I started the atrial fibrillation ablation program here in Thailand about 8 years ago, and this is the procedures that we've done going back to 2006. You can see that we kind of started the program slowly and did this predominantly in people who tried everything else and had a hard time dealing with the arrhythmia despite medication, despite multiple medications. But as we did more and more procedures and saw the success rate with the procedure and got more comfortable, you can see that we're doing more and more of these procedures. We're now doing hundreds of procedures every year because the success rate with the procedure is clearly better than with medications. It's been a really great experience participating with building up the program from the ground up and seeing the improvements in the technology that we have and utilizing some of the newer tools that are available for ablation, newer mapping techniques, newer approaches. But I think that having done over 700 cases over the last 8 years, it gives us quite a bit of perspective on patients that are likely to do well with this and patients who may have problems. It gives us an opportunity to approach we obviously welcome the easy cases where it's going to be an easy fix, we fix it, we move on. We also are sometimes able to tackle some of the more challenging cases that don't necessarily in patients who don't really have great other options. They may not necessarily be the ideal candidate, but they've tried everything else and things are not working. I had a great experience over the last 8 years and didn't have quite a bit of experience and background going back all these years. I want to switch gears for a minute and talk about the other aspect of atrial fibrillation, and that is the risk of stroke. Here is a picture, and it's a little bit, it may be a little bit hard to see from the back of the room, but this is a still frame from an echocardiogram that looks at the heart chambers, and the top portion of the heart is the left atrium, the left atrial appendage. And the gray, oh, I do have a point. So this gray tissue over here is actually a blood clot. You can see that these little dots are about ½ an inch apart. So if you look from here, it's about an inch and a half in length. That's a blood clot in the setting of atrial fibrillation, and that is the source of strokes related to atrial fibrillation. The reason why it forms in the heart is that when the patient goes into atrial fibrillation, the top chamber of the heart tends to quiver and not squeeze the blood very well, and the blood stagnates in the top chamber of the heart and allows for the blood clot to form. When that blood clot dislodges, or a portion of this blood clot breaks off and goes into the, moves over into the neck or into the brain, it tends to cause devastating strokes, and this is obviously an area of great concern. The standard treatment for this, and has been around for decades, is warfarin Coumadin. It's a very, very effective treatment. If you look at multiple different studies that look how well does warfarin perform, it does very well compared to not taking warfarin in the setting of atrial fibrillation. There is a over 50% reduction in the risk of stroke if you take warfarin. Unfortunately, it's a very difficult medicine to take. It interacts with food, it interacts with drugs, the levels are unpredictable, it requires frequent monitoring, and it causes a lot of bleeding. Additionally, when you look at how well can we get patients Coumadin, warfarin, into the proper range, what we find out that when you look at large clinics, only about 50% of the time we can get it to where it's not too high and not too low, because the common problem with warfarin is that you keep on adjusting the dose, but the levels go either too high or too low. It's a very difficult medicine to take. It's a very difficult medicine to manage. It's a fairly dangerous medicine. Fortunately, over the last several years, we've had a number of new drugs that allow us to treat this, the same condition much more effectively. The new drugs, Pradaxis, Xarelto, and Eliquis, have become kind of commonly available over the last couple of years, and they work as well as warfarin, or in some situations better than warfarin. They tend to cause less bleeding. They tend to cause, they tend to have a lot less interactions with food and medicines, and they don't require very tight monitoring because the drug levels are very, very steady. As long as you remember to take your medicines, as long as you don't skip your medicines, the levels are steady and they provide excellent protection against stroke. Unfortunately, there's a number of disadvantages to these drugs as well. One problem that we frequently encounter, these medicines are expensive. They're new medicines, and unless the patient has good drug coverage, these medicines tend to be fairly expensive. The second problem, they're blood thinners, just like warfarin, they cause bleeding. So in patients who have bleeding problems, either bleeding in their stomach or unstable gait or falls, these medicines cannot be used either because basically any kind of blood thinner tends to aggravate bleeding problems. So because of that, there's a number of patients that still cannot take even these medicines that are so much easier to take than warfarin. So up until recently, those patients were out of luck. They were at risk for stroke, and there was nothing that we could do. Fortunately, we've made some progress on the issue, and one of the things that we do here at the Louis Owen Heart Hospital, and this is really the only site in East Texas that has access to this technology at present time, is the left atrial appendage closure technique. Where basically, we go and do a procedure that allows us to close off that spot that I showed you a little bit earlier, where these blood clots form in the first place. By physically or mechanically excluding that spot out of circulation, preventing the blood from coming in or coming out, you prevent the blood clots from forming in the first place, so you don't need to put people in blood thinners. So here's a cartoon that shows how the procedure works. And this is just a cartoon, but it kind of shows what happens. This is a little pouch on the side of the left atrial appendage, and here's the thing kind of in cross-section. This is where the blood clots come from. So we do a heart catheterization. We'll put in a little wire inside the heart, and we'll put a special catheter in the wire inside the heart to stabilize the heartbeat, to make sure it doesn't move while we're doing the procedure, to provide a stable platform. We'll put in the second catheter, the second wire, in the pericardial space in the sac that surrounds the heart. And this is done all through needle sticks. There's no incisions, and there's no cutting, and there's no opening of the chest. There are two magnets that allow us to stabilize those wires to make sure that it doesn't move. And then we'll put in a device that looks like a lasso around the left atrial appendage, and we move it up carefully to the neck of the left atrial appendage, and we tighten the noose of the lasso catheter to exclude this portion of this left atrial appendage from circulation. This will prevent blood from coming in and coming out. So it will prevent blood from coming in and blood clots from coming out. We then remove the catheters that allow us to get access. We tighten the noose. We remove the lasso catheter that allowed us to position this suture, the little wire that allows us to close it. We use a remote wire cutting device. We cut it off. And we take out our hardware out of the heart and out of the tissues. And all you're left with is a little suture that closes the left atrial appendage. And what you see is that usually within a few months, or usually within, certainly within a year, the left atrial appendage atrophies and goes away. And what we've seen is, with this technique and with some of the other techniques, is that when you do this, close off the left atrial appendage, it seems to reduce the risk of stroke dramatically, on par with what you would see with warfarin, but again, does not expose the patient to the risk of complications from long-standing blood thinning. So this is one of the options that's been available to us for the last year or so. We've done quite a number of these procedures with great success. It works well. Patients seem to tolerate it well. They usually go home the following day. We actually did one of these procedures today. The patient's doing great. She's awake and alert and is asking when she's going to go home.
What you showed us a few moments ago, the smaller portion there, that was not the entire left atrium, was it?
Correct. We don't occlude the entire left atrium because you need the left atrium for the blood to go around.
Okay.
We close off just the left atrial appendage, which is a small pouch on the side of the left atrium, which is typically where the blood clots come from. Now, you could have blood clots coming from other spots, from the left atrium, from the left ventricle, from the carotid artery, from a variety of different things. But it seems that probably 98% of the blood clots come from the left atrial appendage. So if you can control that, that's probably where the money is, because remember Willie Sutton, somebody asked him, why does he rob banks? That's where the money is. So that's where we go, and that's where the clots are.
Well, what is the function of that appendage? Why is it there?
I think that's a great question. The function of the left atrial appendage is actually not well understood. We think it is an embryonic remnant. As the baby is developing in the mother's womb, this is one of the original chambers that forms the heart. But as the baby grows and the heart grows, the rest of the heart grows and becomes bigger. But this little pouch remains kind of a smaller size and does not seem to contribute very much to cardiac function in the future. We're not entirely clear as to why it's left there and why it looks different. But what we do know is that in many patients, as you amputate the left atrial appendage, if you close it off or if you cut it off, it does not seem to interfere with the heart function. We haven't seen any problems. This is a relatively new procedure. We've been only doing this for a few years percutaneously, where we don't open up the chest to do it. But this same type of procedure has been done for decades with an open heart surgery, where you open somebody's chest, saw through the breastbone, put the heart on pump, put the clamp on the thing, sew it off, close everything back together, and it works great. The problem is that it's a major open heart surgery, so that makes the limitation. So in patients who need open heart surgery for something else, we'll go and amputate the appendage or close off the appendage surgically, and we do that all the time. But we're talking about patients who don't need open heart surgery and who don't want open heart surgery and who are otherwise doing okay. So for those patients, this is an option of a percutaneous approach.
Would that be similar then to an appendix in your intestine?
Correct. It is a fairly similar kind of thing, and I guess it's quite similar down to the name, but it's the same thing. It's a part of the intestine that's kind of part of the way the intestine has developed, and it's there. And in the majority of people, it doesn't cause any trouble, and it sits there. But in some people, it does cause trouble with forming blood clots, and then it needs to be cut off. Yes.
Once you tie that off,
Uh-huh.
I mean, does it dry up and drop off? Since you didn't mention that your sticks to go in there, what if it comes over?
It don't come off.
That thing slips off. I mean, does it breach to the heart?
Right. What happens is over a course of several months, it usually atrophies and shrinks up, and usually if you do a CAT scan looking for what happened, it converts to kind of small soft tissue and ends up going away. The reason for that is because when you tie that suture around the neck of the atrial appendage, it cuts off the blood supply to the tissues in the atrial appendage, and it shrivels up and dies and goes away. So if the suture falls off 6 months from now, it's not going to be an issue because there's no atrial appendage left. There's only some scar left in its place. We've done this thing for several years now, kind of in studies, kind of looking at how well does it work. So before we start doing this kind of across the board, we do a number of studies to see how it works, and we kind of follow these patients. Typically, if you get the sutures in the right place and you're able to kind of get this closed, if it's closed at the time of the procedure, it's exceedingly rare for the thing to reopen at any point in the future, because basically once it's tied off, it's not going to reopen.
Well, that's all circulation. Die.
Assume that.
Within the body.
So there is a possibility of getting in trouble while you're trying to tie it off, while it's still not under control. But if you don't run into trouble while you're having the procedure, it's not going to reopen later on.
The big suture.
I'm sorry, how big is the suture?
I said, big suture.
Yeah, what we do is we have this suture that's delivered through these catheters because we don't really open the chest. We advance these sutures with long instruments and we tie it off around the left atrial appendage and then we cut it off and we'll leave the suture in there.
I had a couple bypass.
Mhm.
They have taken that out at that time?
Sometimes they do and sometimes they don't. It depends on a number of different details. It depends on the type of the procedure and some of the circumstances, because sometimes, depending on the type of exposure and the type of surgery, sometimes if you do a triple bypass with kind of conventional techniques, if you do it on the bypass machine, you stop the heart and you do the bypass, it's easy to access the appendage and cut it off. If you do it with beating heart surgery, then it is more difficult to do that. Sometimes you have good exposure, sometimes you don't. Sometimes it's easy to kind of get to it, sometimes it's behind the heart. Sometimes if you do it electively, it's easy to do. Sometimes if it's more of an urgent procedure, that kind of stuff, maybe not such a good idea to spend an extra 20 minutes sewing things off. You want to close up the chest and move on because you have more trouble with recovery. So sometimes yes, sometimes no. There's not really a kind of across the board. It doesn't always happen automatically, but it does happen in some patients. What we do is in patients who have known atrial fibrillation and have trouble with the arrhythmia, we typically discuss that with the surgeons. We work very closely with our heart surgeons. Basically, a lot of this stuff, the way it's developed, the way it's implemented, the way we do it, has to be a really collaborative effort between the cardiologists, the arrhythmia doctors, the heart surgeons, the x-ray doctors, because basically, as you can see, there's lots of aspects to this, and nobody can kind of cover the whole thing from their own silo. So we've been working very closely with surgeons trying to figure out what's the best approach. For some people, it's the surgical approach. For other people, percutaneous approach is much better. We've been kind of blessed with a good team where basically we can work together without kind of much trouble and friction, where we can kind of work out and have the best approach we can.
Does this fix the AFib or does this just fix the stroke problem?
This type of procedure only fixes the stroke problem. It does not fix AFib. So if you have symptoms related to AFib, the other category of problems that we mentioned, then you would need medication, or you would need an ablation, or you would need something else. The problem is sometimes if patients need an ablation, you would need at least a short-term round of blood thinners. In patients who are intolerant to the blood thinners, sometimes you can't do an ablation unless you do one of these first to reduce the risk of stroke. So that's one of the. So some of the stuff is a little bit convoluted, but we do have a number of tools to kind of deal with this. This is what it looks like in real life. So basically, this is not something that you open up the chest. You can see this is the device that has the lasso catheter. So you can see this is the surgeon's kind of fingers, and this is the catheter that you insert under the breastbone. And then when you're done, you pull it out. There's no stitches. There's nothing else. This is one catheter, and this is the second catheter that we insert through the vein in the leg. This is the patient's head over here, and this is their chest, and this is the leg, and this is the catheter that we use to insert. This is the X-ray camera that we use to see what we are doing. So it's a totally percutaneous procedure. The lady that we did the procedure on this morning, she was asking if she could go home today. So I told her no, tomorrow. So in summary, I'm going to open it up to more questions. Atrial fibrillation is a very complex condition with lots of different types of symptoms, lots of different presentations, lots of management options. We don't really have a cure. We don't always have a perfect approach. But in this day and age, we have a lot more tools than we used to have just a few years ago. We are really excited to really have access to all the tools, not just some of the tools, but all of the tools that you can possibly need to fix atrial fibrillation. We have access to medicines, we have access to different ablation techniques, we have access to both surgical and percutaneous appendage closures, we have access to any of the tools that you possibly can need to try to get it under control. So the challenge is to try to figure out which tools and which techniques are best for a given individual patient, and that remains the challenge of treating atrial fibrillation. How do you come up with the best approach? But we're excited to have the tools available, and unfortunately, we do have some expertise in kind of using this stuff, so hopefully we can kind of balance some of the risks and the benefits.
Doctor, I'm interested in noticing a irregular heartbeat, and I think these details here that I have a situation called PVC.
Right.
Can you talk about that for just a moment?
Right. So when we talked about different type of arrhythmias, different electrical disturbances, there's a whole list of them. Atrial fibrillation, what we talked about, is an abnormal heart rhythm that comes from the top chamber of the heart. But you can have other problems. One of them is PVC. PVC stands for premature ventricular contractions or complexes. And basically, those are abnormal heartbeats that come from the bottom chamber of the heart, and again, compete with the normal heartbeats. You have a couple of normal heartbeats, and then you have an abnormal heartbeat that comes from the bottom chamber of the heart. Doesn't allow the heart to fill with blood, and just makes the heartbeat irregular. There's a wide range of symptoms that may come with this. Quite a few people have PVCs and are not even aware of them. They are there, they don't cause any trouble, and we usually ignore them. If they're not associated with symptoms, if they're not associated with fainting spells, if they're not associated with heart disease, we leave them alone. Unfortunately, in other people, these PVCs cause a lot of trouble. They cause discomfort, they cause palpitations, they cause people to feel weak because of the competition between the normal heartbeats and these abnormal heartbeats that just kind of run randomly and just kind of pop up whenever, wherever. In those type of situations, we're trying to control PVCs, and there's a number of different things that we can do to try to get it better. We can typically use medications to suppress them. There's a number of these medicines, similar to medicines that were listed for atrial fibrillation, that may suppress PVCs and make them go away to where the normal heartbeats take over. Sometimes it doesn't work, and sometimes we do an ablation. If all the PVCs are coming from one spot, you can frequently find that one spot and just burn it, destroy that one tiny little spot. These spots are usually microscopic. They're a couple of millimeters in diameter. If you can find the spot and burn it off, makes it go away and instantly cures the problem. So in some people who have symptomatic PVCs, it causes them a lot of trouble. It doesn't go away with medicine. We go and find the spot to burn it out. Typically, when a patient, when somebody presents with PVCs and has PVCs as a problem, we'll look at a few different things. We'll run some diagnostic tests to see, is it dangerous or is it not? If it's not associated with any kind of heart disease, if there's no weakening in the heart muscle, if there's no other problems that are provoking these PVCs, we ask the patient, does it give you any kind of trouble? If it doesn't give you trouble, we say, don't worry about it, move on. If they do give you trouble, then we'll go and treat them. And we usually treat them either with medicines or with an ablation, again, depending on what the patient wishes and how bad the symptoms are and what we've tried before. Are they likely to tolerate this? Are they likely to tolerate the other? Does that make sense?
Thank you very much.
Can you just...
What do you actually do? When you say burn?
Right. So the way it works is, for example, in a patient with a PVCs, there's usually one spot that has abnormal electrical activation. There is an area of the heart that fires inappropriately. So what we do is we take a needle and we put it through one of the blood vessels in the leg, typically through the femoral artery. We'll put a wire, an electrical wire, through that vein, we thread it up into the heart, and we go and find that spot. We move the catheter, this electrical wire, we move around and find that spot where these abnormal heartbeats are coming from. When we find the spot, we get the electrical wire right on top of the problem area. And then we turn on special kind of electrical energy that heats up the tip of the catheter and delivers some electrical radiofrequency energy that destroys a small piece of tissue, usually 2, 4, 5 millimeters in diameter. So it's a tiny little area where the catheter tip is. When you put this catheter over the problem area and you deliver the electrical energy, it cauterizes or destroys that one spot. Typically does not have any impact on the rest of the heart. If you destroy that spot, you take out the catheters, you wake the patient up, and you say, we're done, go home.
Go home.
Go.
Come a long way.
Is, we're in this scheme of things that is premature heartbeat, it's called.
What?
One time I had a premature heartbeat. Beat a long time ago. And I've never had any, episode since, but there was this thing, have you got a premature heartbeat?
Right. Well, these when we talk about PVCs, those are the premature heartbeats, and the reason why you feel them is because they're premature. They happen before the normal heartbeat, so they get ahead of the line, and instead of the normal steady heartbeat, you get this premature heartbeat that kind of gets in there and sometimes causes thumping in your chest or bouncing in your neck or just kind of not feeling right, feeling your heart kind of skipping. That's the premature beats.
I have a pacemaker. It supposedly gives me a floor of 60 pulse. Occasionally I get readings. I check my blood pressure with a little machine regularly about the same time of day, usually in the morning. I'll get heartbeats down in 50s. Is this the machine or is this?
Well, it can be a couple of different things. We see that phenomenon with quite a bit of frequency. There's a few different issues that may be happening. One issue is some of these machines that check your pulse rate use different techniques to kind of figure out what it is. I mean, it's not a human, it's a machine, and it tries to kind of guesstimate the pulse rate the best it can. And some of these machines are not entirely precise. They may not necessarily, they may give you a number that's not a mile off, but it may be kind of an approximate thing, and sometimes it doesn't pick up certain heartbeats, and give you a number that's kind of approximate. So the machine may make a mistake, and sometimes we see that even in the hospital where the automated machines that determine your heart rate sometimes get confused by stuff. And it's more common in patients with pacemakers, for whatever reason, machines have a hard time picking up. The other possibility is that you may actually have an effective heart rate that's in the 50s, despite the fact that the pacemaker is set to 60. And what does that is if you have premature beats, sometimes if you have some premature beats, they generate a heartbeat that the pacemaker sees and counts and resets the timing. But because these heartbeats are premature, the heart did not have time to fill with blood, so it's an empty heartbeat. It squeezes, but nothing comes out of the heart. So even though there is a heartbeat, there's no blood coming out of the heart. So the machine is just measuring how much blood's coming to your finger or to an artery in your arm or something like that. It doesn't see it. So that's how sometimes we get low pulse rates in patients who have a pacemaker that shouldn't have a problem. But that may be another explanation.
My normal was about 50, 52 anyway before I
got the pacemaker.
Right.
Is the heart rate of 50 very bad? No.
I'm sorry?
Is the heart rate of 50 okay?
The heart rate of 50 is not a problem. It actually is a very complex problem that we don't really have very straightforward answers. Normally, if your heart rate is 50 and you're feeling fine, it's perfect. It's perfectly fine.
Around 60.
Around 60? Well, 60 is normal heart rate. The typical, we consider normal heart rate 60 to 100. But in people who have a heart rate of 50 and they're doing fine, we typically don't want to tweak it and we don't want to mess with it, it's fine. However, in patients who have a heart rate of 50 and it doesn't really go up when they go and try to exercise, that's a problem, because basically your heart rate is supposed to correlate to your activity level. In somebody who is sleeping, you don't really need a very fast heart rate when you go to sleep. However, if you're going to go and try to run up a flight of stairs, your heart rate better go up. The maximal predicted heart rate is 220 minus your age. So if you do some math in your head, it's actually quite a bit.
It's 220.
So if your heart rate doesn't speed up when you exercise, when you exert yourself, it's a problem, and your exercise capacity is going to be impaired. You're not going to be able to perform as well as you would like. So that's a problem. But if your heart rate's 50 at rest and you're feeling fine, that's perfectly fine. You don't need a pacemaker. You don't need to do anything about it.
I have a blackout, just all of a sudden. And last year, I can look back now and say that I've done it all my life. I can just be walking along talking, and all of a sudden I'm on the ground.
You know, that is a fairly common problem. We deal with quite a bit of fainting spells and passing out spells in the area of electrophysiology or arrhythmias or heart rhythm. Basically, if you look overall, the diagnosis of syncope or passing out is an extremely common diagnosis. Everybody passes out at some point in their life. But some people pass out more often than others, and some people get into a lot of trouble with that passing out. It depends on what's the nature of this passing out. If you're passing out because your heart's not working, you're likely to pass out again, and you're likely to hurt yourself, and one of these days your heart may quit. So this is something that we treat very aggressively, and we go and study it and kind of figure out what the problem is, and frequently you need a pacemaker or a defibrillator or some other kind of treatment. On the other hand, we see quite a few patients that pass out because they have a drop in their blood pressure. They get dehydrated and the blood pressure drops and they pass out. That's a benign problem. It doesn't hurt anybody. As long as you don't break something when you pass out, you can be fine.
I've been very fortunate. I haven't broken anything, but I have been severely hurt.
Yeah.
Many times, in fact.
So it is frequently a challenge because it's kind of like when you take your car to a mechanic and ask them, how come it's making this noise? And he says, well, let's go listen. Well, it's not making that noise. So that's the problem with passing out spells. Nobody ever passes out at the doctor's office. They pass out at home.
Right.
Fortunately, we do have quite a few different tricks that we use to try to find out why does somebody pass out. We usually talk to them to kind of get a sense for what's the problem, because common things happen commonly, and we can kind of put some of the story together with what happened to get a sense for what it is. We get an EKG, we get some other heart tests to kind of round up the usual suspects. In somebody who has a really beat up heart and it looks like it's about to quit, if they're passing out, that's probably because your heart's quitting. In somebody who has a perfectly normal heart, it's unlikely that we're going to find very much wrong as far as the arrhythmias we may want to look at. Once we get some of this non-invasive testing, we usually go on to kind of more involved tests to find out why are you passing out. There's a number of different monitors that we can use to try to capture some of these passing out spells. In people that we can't really get to the bottom of it, we can sometimes do an electrophysiologic study where we bring you to the hospital and go try to provoke an abnormal heart rhythm and see if there's unstable rhythms. Depending on what we find, we can go and treat it accordingly. Nowadays, we have some of the new and the best stuff. We would probably talk for a whole hour about the newest and greatest implantable devices that allow us to find out what the problem is and treat different heart rhythm problems. There's different devices that we can, that, for example, you can have a tiny little electronic chip that you implant under the skin, and it's basically injected through with kind of big fancy syringe. We inject the chip under the skin, and it has a battery and the wireless transmitter that sits there. It can run for 2 to 3 years, looking at your EKG. So if you have passing out spells that are severe, but they don't happen once every 6 months, it's impractical to keep you in the hospital for 6 months. It's impractical to put you on the monitor for 6 months. But we can go and inject that chip under the skin, and it sits there and monitors your heartbeat. And next time when you have a stop 6 months from now, it will record your EKG and tell us it's a slow heartbeat, it's a rapid heartbeat, it's a seizure, it's none of the above. So we can kind of get the information out of it, non-invasively figure out what it is, and go and treat it. So there's a number of different tools and tricks that we have to try to find out what's the problem, how do we treat it. Sometimes it continues to be difficult to diagnose, but most people, we can get to the bottom of it and get the question answered pretty good.
To the point that I'm in the wheelchair because I'm afraid I'll pass out and get severely hurt. I mean, I've been hurt a lot, but I mean, really. And, you know, I have the loop recorder planted. And every time anything like this happens, and we come in and have it downloaded, they say there's nothing there.
Well, you know, that may be helpful also, because basically, pass out and it shows that you have no heartbeat, that's the problem. If you pass out, but at the same time your heartbeat is perfectly steady, that's an indication that it's not an arrhythmia. So it may be a blood pressure problem or something else. So then we go try to do some tests to see, is this a blood pressure problem? How do we diagnose that? And how do we treat that? And those are some of the issues that we can kind of get better clarity and better understanding by doing additional tests. So sometimes it's not what you see, but sometimes it's what you don't see that kind of tells you what the answer is.
You gave a formula a while ago for maximum heart rate.
Yeah.
Would you tell me that again?
220 minus your age is what's considered the maximal predicted heart rate.
Now, what was that? Predicted heart rate?
Well, we predict that most people should be able to achieve that type of a heart rate when they go exercise.
Oh, okay.
So if they don't achieve it, there's something wrong with the heart rate not going too fast. If they go faster than that, then it's probably also there's something not quite right. Either you're deconditioned or you have abnormal heart rhythms or something like that. But it's 220 minus your age.
Okay, thank you.
You talked about the ideal candidate for an ablation. How do you determine that?
Unfortunately, some of the stuff is a little bit subjective, and some of the stuff has to do with experience. Somebody who has done 4 of these will probably have less insight into how the thing works than somebody who's done 700. So, but there are certain guidelines, certain things that we've kind of learned from experience, our own experience or experience elsewhere, and kind of seeing a number of people kind of go through this. You need to look at the expected success rate. How well do you think the patient is going to do with the procedure, number 1. And number 2, you need to look at the risk. If the success rate is likely to be high and the risk is likely to be low, you should definitely do the procedure. If the success rate is likely to be low and the risk is high, maybe that's not such a good idea. There's a number of combination of these things that can make it difficult to figure out. But basically, we'll look at the expected success rate. What do we think is going to be a success rate in this particular patient? And then we'll look at what is the complication rate that we expect in this particular patient. So as far as the success rate, it's different depending on the patient, depending on the procedure. So let's say for atrial fibrillation, if you have paroxysmal atrial fibrillation, meaning it comes and goes, that carries a very high success rate because usually that's an indication of an early stage of the disease. You typically won't have extensive scarring everywhere. You'll have limited disease. We'll be able to kind of go and cut it out and move on. It's kind of like with cancer. It's a whole lot easier to operate on somebody with stage 1 or maybe stage 2 cancer. We really don't like to deal with stage 4 cancer because by that time it's all spread all over. It's very hard to find out. So if you have paroxysmal atrial fibrillation that comes and goes, that's an indication that it's a low-grade disease. It's going to be easier to fix. The success rate is high. If you have no or minimal heart disease, the success rate is going to be high because in patients with a lot of heart disease, weak heart muscle, bad valves, stretched out heart, you typically tend to form a lot of scar tissue on an ongoing basis. So I go and I fix it, and 6 months from now you go and form a bunch of new scar tissue. what did we accomplish? That's not like a same thing in patients with bad lung disease. If you can't get enough oxygen in your heart because your lungs are at end stage, the success rate of this procedure is going to be likely much less. So we're more hesitant. So those are some of the issues that kind of give us some ideas of how successful the procedure is. The other thing that we'll look at is the likelihood of complications. In younger patients, in healthier patients, you're much less likely to run into complications. People who are older have more potential for trouble with their blood vessels, more potential for other conditions that make them sick, whether it's their heart, whether it's their lungs, or whether it's their kidneys, or whether it's diabetes, or whatever else that can increase the likelihood of complication. So there we kind of look and see what's the risk. In somebody who's in pretty good physical shape, chances are that your complication rate is going to be quite low. Overall, the complication rate for these types of procedures probably on the order of 1%. In healthier patients, it's less. In sicker patients, it's more. So we try to kind of figure out for a given patient what's the expected success and what's the risk. And depending on the ratio of those, we say, oh, you definitely should get it, or I don't know about that, let's try some more medicine.
On getting rid of the pouch on the atrium, if you got rid of that pouch, would you still need to fix the Draco?
No, so if you get rid of this pouch, unless you have other reasons that make you bleed a lot, you wouldn't need to take the blood thinner. So we predominantly do this type of procedure for people who have some type of problem with taking blood thinners. If for whatever reason you can't take Xarelto or some other kind of drug, we would go and look for these types of procedures to try to get the thing fixed and take you off the blood thinner.
What causes AFib?
You know, that is a great question. If I knew the answer to that, I'd be on my plane to Stockholm to get my notes right. We don't know. We don't know. There are some patients who have atrial fibrillation because of bad valves or weak heart muscle, because there's leakage of blood into the left atrium that stretches it out and causes it. There are some people who get atrial fibrillation because their thyroid is overactive and it revs up your heart rate and can put you out of rhythm. There are some patients who get AFib because they have lung disease or sleep apnea where they don't have enough oxygen to the atrial tissue at night or during the day for that matter, and put them out of rhythm. There are some patients who have bad genes because basically their dad had AFib and their mom had AFib and their grandparents had AFib, and it just kind of carries on in the family. But well, in some people we can burn out the AFib with the ablation and it doesn't come back. I would hesitate to say it's a cure because again we don't understand what's driving it. But that's the closest that we can get to a cure. Unfortunately, after you go through all of those things, the causes of AFib, we're left with a very large category that's probably responsible for 70–80% of AFib, where basically we have not a foggiest idea. They have AFib because of bad luck, and we just don't understand them. They have AFib.
Is there any correlation between AFib and angina?
Those are two separate problems. Angina typically is a plumbing problem. If there's blockages in blood vessels of your heart, you get angina. AFib is an electrical problem, and it's electrical short circuits that can make your heart not work well. So those are two separate issues. Now, in certain situations, you could have them go together because a lot of the time when you have AFib, your heart rate will go way up. And if that happens, and somebody who has a bunch of blockages, if you speed up their heart rate, you may end up with angina. Think about it. When you do a stress test, what you do is you try to rev up somebody's heartbeat so fast to see is there enough blood flow with a rapid heart rate. Well, if you're not really running on the treadmill, if you're just sitting on the couch, and your heart goes out of rhythm into AFib and goes sky high, the heart rate goes sky high, that may certainly give you angina. But those are not necessarily one causing the other. They're just basically two problems that exist in parallel.
The plans are being made to have an AFib procedure.
Mm-hmm.
Is it important that we back off our thinners, maybe on aspirin or other things?
You know, that's an interesting issue, because basically for many years we've been kind of very careful that basically anytime you're doing kind of surgery or procedures, we want you off the blood thinner so you don't bleed when we stick you with needles. It's fairly obvious, and that's kind of what we've done. Unfortunately, what we see is that AFib is one of the most common causes of stroke. And these strokes are coming from blood clots that form in the left atrium. So when we go and manipulate the left atrium and burn stuff in there and do all sorts of stuff, it actually increases your chances of getting a blood clot. And that is something that we've been very concerned about for a number of years, that basically you go and start messing with this stuff and then you'll form a blood clot and that'll give you a stroke, so that's a problem. So over the last several years, we were kind of closely looking at the different treatment strategies. How do you manage blood thinners? Do you stop it in advance? Do you stop it kind of halfway? Do you not stop it at all? What we've been doing in many patients with atrial fibrillation, we don't stop blood thinners around the time of the procedure, because what we've seen is that the rate of bleeding for these types of procedures, although it's not zero, it's actually very low. In most patients who develop bleeding, we can usually treat it, and treat it fairly effectively and get it better and move on. On the other hand, if you get a stroke, a lot of the times, that's something that doesn't recover very well, and it's not really an effective treatment strategy. So we're much more afraid of a stroke than they are of bleeding. So because of that, if you're going to have an AFib procedure, we typically leave you on the blood thinners, and depending on kind of what exactly we do and how we go about it, sometimes we'll modify your blood thinner regimen, but we typically leave you on the blood thinners for these types of procedures.
See you again.
As a part of the atrial fibrillation, did you say that you had to be on blood thinners as a portion of this whole process, right?
Yes.
Okay, my question is, because I attended another seminar somewhere else, and they were saying that you had to be a certain distance from, say you had another surgery.
Right.
That, because it blowed out, and you had an aneurysm and didn't know whether, or you had a surgery too close to this procedure, that the blood thinner would blow that, could cause problems for your previous surgery. So
Right.
what is the time?
There's, I think it's an excellent question, because basically when you go and we kind of got this thing figured out. You put somebody in blood thinner, you go through the procedure, you kind of finish the procedure, you move on. So we got the plan. The problem is that we don't really live in an ideal world. We don't deal with patients who have just AFib. You have AFib, but you can have a variety of other different problems that come up. Life happens, and you have other issues. You may have other surgeries, other procedures, other conditions that interfere with this. So how do you manage it? So being that we've kind of dealt with a number of these problems, a number of these issues over the years, we're typically very careful while we can't really plan for every possible contingency, we usually go and talk to people and try to kind of figure out how to plan this. And somebody who has a known medical issue, something that needs an intervention, will usually go and try to figure out which one do we do first. If you have a bunch of bad teeth that are giving you trouble that need to be pulled, you really don't want to do that 2 weeks after your AFib ablation when you're on full dose blood thinners, and we really don't want to stop them. So if there's a problem, we may want to go and get your dental work done, and then we'll wait for a little bit, and then put you on the blood thinner. Obviously, it doesn't work for emergency surgery. For emergency surgeries, we interrupt the blood thinners and we go and do what we need to do. But if you have a planned elective procedure, we always kind of go through the thing. What makes sense? Do you do this one first and then the other one? Or do you do the other one, get it out of the way, and now do the ablation procedure? So it depends on the type of procedure and the type of the condition and what it is. There are some patients that we have been following with atrial fibrillation for a number of years, and they suffer severely from atrial fibrillation, and we can't do anything about it because we can't put them on the blood thinners. So we can't really control their rhythm very well because we can't do a cardioversion. We can't put them on medicine. We can't do an ablation because we can't put them on blood thinners. There's a number of these patients that, fortunately, over the last year, we've been able to help those because we go and we do this lariat procedure, the last procedure where we block off the left atrial appendage. Well, now we can go and do it without the blood thinner. So that's really an option that has become available and that kind of helps kind of get through the maze of all the different challenges where we want you in the blood thinners, we really don't want you in the blood thinners. But that's kind of what makes it challenging, and that's what makes it individual. So the bottom line is that treatment remains highly individual. That there's not really a cookbook approach.
What's the difference between Bardoxa, Exalto, and Eliquis? And why would you be on one rather than the other?
You know, those are very similar drugs. They accomplish the same goal. They have a few subtle differences in the way they work and the way they handle. They probably have more similarities than they have differences, but some of the differences have to do with the drug metabolism. For example, Pradaxa is cleared entirely through the kidney. And in patients who have liver problems that take certain types of medications, that's the best drug to take because it goes through the kidney and it doesn't affect anything else. Whereas Xarelto and Eliquis are predominantly metabolized in the liver. So in patients who have borderline kidney function, you may want to go with Xarelto or Eliquis because you're not so worried that the kidney function is going to change and the drug levels are going to change. So that may be one of the differences. Pradaxa may have perhaps a slightly higher efficacy at reducing the risk of blood clots, but it also has a slightly higher risk of GI side effects, the stomach side effects. Some of these other drugs may not be as potent, as powerful as Pradaxa, but they're much better tolerated, they don't disturb your stomach. So obviously the patients where so you got to look and see where you're going to likely to get in trouble. Somebody who has bad problems, somebody who has blood clot like I showed you, we're going to go and hit them with the heaviest guns that we got. And somebody who has a very sensitive stomach and who's frail and is having issues and we're really afraid of bleeding, we're going to try to get them the drugs that are kind of have the least likelihood of disturbing your stomach because of drugs.
I'm on Bardoxa, and I found that take it with food.
Right. It seems that taking it with food helps, and it seems that sometimes if you take certain types of antacids or something like that, that may help. But in some people, it's difficult. If it upsets your stomach, we're going to try to figure out something else. And depending on kind of what other medicines you take, what other medical conditions you have, the others may be just as good of a choice. Maybe something.
Yes, my daughter was coming into a holistic healing to a point, and she had said that if we were able to have a stroke, to tell the physician to do a magnesium sulfate IV. Have you ever heard of that procedure?
Well,
it's supposed to, supposedly keep the damage from the stroke.
The stroke is a challenging condition. There's a number of different types of strokes. You can have a blood clot that causes a stroke. You can have a bleeding in the brain that causes a stroke. You can have a number of different conditions that cause a stroke. Depending on the type of stroke, the treatment may be different. There are some suggestions that perhaps magnesium may reduce some of the injury to the brain tissue from insufficient blood flow related to the stroke. But it's going to be obviously variable depending on the nature of the stroke and the type of the stroke.
would they be able to tell at that point?
A lot of the times we can determine the type of stroke when you initially present. When a patient presents to the emergency room, we'll usually do an examination to kind of give us a sense of, yeah, it's a stroke. We usually do some type of imaging study like a CAT scan or an MRI to kind of figure out what's going on. That will frequently kind of guide us to what it is and how to treat it. And then we try to come up with the best approach as far as how to minimize the symptoms and the damage related to the stroke.
Well, if I weren't the victim, or the patient, but I was with the patient, would that be something that I would want to immediately suggest to the physician at the time about having,
I think that may be a reasonable strategy to suggest, but I think that they're going to need to look at a number of different issues and try to come up with kind of the best possible strategy, because depending on the type of stroke, depending on the nature of the problem, you may need to do certain interventions in a very time-sensitive thing.
That's what she was saying.
So if you need blood thinners to break up the blood clot, you may need to do this real quickly. You don't want to kind of get distracted with other things. If you have bleeding in the brain that compromises certain tissues, sometimes you need emergent neurosurgery to kind of get help with that. So depending on the type of a problem, type of an issue, you're going to need to kind of individualize the treatment strategy and deal.
Well, I guess my question was, is that something that most physicians, or surgeons would know about, anyway? I mean, is that one of the options that they would consider at the time?
Well, I think that's hard to tell, because there's a variety of physicians out there, there's a variety of different approaches. But typically what we do is we usually use certain guidelines, where basically we don't go and start kind of trying random things, or whatever makes sense. Usually have certain types of treatment algorithms that for these types of strokes or these types of conditions, these are the things that have been shown to work, and we'll try to go and do those things. These things may be harmful. These things may or may not help. So we kind of go through these algorithms and try to select what's going on. So I think that most physicians in the emergency department, people who can encounter stroke victims kind of firsthand, usually have quite a bit of familiarity with the different.
Have you ever done that yourself?
I typically don't treat strokes acutely, because I deal with abnormal heart rhythms. So I deal with the cardiac aspects of it, and would frequently need to work together with neurologists and emergency department physicians and other and the neurosurgeons to try to kind of figure out what's the best approach. I typically don't treat the stroke directly. I treat the cardiac issues surrounding the stroke.
If that appendix has a clot of blood in it, is there pain associated with it?
No, absolutely not. This picture was actually from one of my patients who had no pain, no trouble whatsoever. She feels fine. You can't feel it. The only time that you have a problem is after this thing dislodges and goes into your head. But at that point, it's frequently too late to do anything.
Well, I think this has been very informative. I want to thank Dr. Weiner for coming out tonight and talking to us.